Hello and good evening, everyone. Today we will be talking about gastric outlet obstruction. This is a very important clinical condition where you see obstructive pathologies in the distal stomach and proximal duodenum, usually, and it's a condition that you commonly see in chronic duodenal ulcer or patients presenting with gastric tumor, especially tumors involving the distal part of the stomach. And they classically present with recurrent vomiting, non-bilous vomiting. And you see most of the time the patients are looking malnourished with chronic dehydration. So this is a very common condition which, if it is not managed adequately, even the wrong management might tilt patient into some form of complications. Okay, so we are going to talk about gastric outlet obstruction. GOO is commonly known as GOO, a clinical and pathophysiological consequence of disease process that produces a mechanical impediment to gastric emptying. Obstruction is at the pyloduodenal area. Okay, many cases are not isolated gastric pathology, but rather involves duodenal or extraluminal disease. So this obstruction could result from, okay, the distal parts of the stomach, commonly the antral region, or it could be from the proximal duodenum, or it could be from an extraluminal compression, or especially of the first and second parts of the duodenum. The two common causes of gastric outlet obstruction are gastric cancer and pyloric stenosis secondary to peptic ulceration. Now, you should know previously peptic ulcer was more common, but with improvement in drug treatment for peptic ulcer due to advent of potent medical treatment, gastric outlet obstruction should be considered malignant until proven otherwise. That is in the developed countries. You rarely see gastric outlet obstruction occurring from cicatrizing or chronic duodenal ulcer, especially in the developed countries. However, in Africa and India, gastric outlet obstruction is still a common and early complication of duodenal ulcer. So this is, you should take note of that. Usually, duodenal ulcer or generally peptic ulcer disease and their complications are no longer seen, especially in developed countries. So GOO, you commonly see patients with gastric cancer, especially in developing countries. And you will see in the pathology of this disease, those patients that will present with gastric outlet obstruction secondary to duodenal ulcer or chronic duodenal ulcer, they tend to have a elongated and a distended stomach because it's a benign pathology. You might even see a stomach that is extending up to the pelvis due to prolonged contraction, dilatation, and hypertrophy of the muscles. But in malignant condition, because the duration of the clinical course of malignancy is shorter, so it might not give an ample time for the stomach to achieve such dilatation. to extend up to the pelvis. However, this is not exclusive. You might also see a patient with a dilated and elongated stomach up to the pelvis, and it is still from malignancy, but you should know it is commoner with the benign condition as compared to the malignant ones. So we'll briefly look at the anatomy of the stomach and the duodenum, and we should know that the stomach connects the esophagus to the duodenum, and it is located, it lies in the epigastrium. Okay, this is the epigastric region. Yes, left hypochondrium, as well as some parts of the umbilical region. Sometimes the stomach might elongate in GOO to even reach the pelvis, okay, because of chronic obstruction. Yes. So, but basically, the stomach occupies the epigastric region, left hypochondrial region, as well as the umbilical region. And you can see it has a fundus, a body, okay, the antrum, okay. So this is the pyloric antrum. It has the pyloric canal. All in all, it's called the pyloric antrum. And you can see the stomach has a lesser curvature and a greater curvature. It has orifices, the cardia, as well as, okay, the duodenal orifice, the pyloric orifice. It has surfaces, the anterior and the posterior surface. So obstruction usually is around this pyloric area that will prevent emptying of this gastric content into the duodenum. The stomach, an empty stomach is J-shaped. As we mentioned, it has the cardia and the pyloric. That is two parts. Okay, we won't go into these details, but you should know it has the cardiac orifice, pyloric orifice, the lesser curvature, greater curvature, the anterior and the posterior surface. We mentioned all this. Okay, so the muscular wall of the stomach, it consists of 3 layers of smooth muscle: the outer longitudinal, middle circular, very thickened in pyloric area to form pyloric sphincter. So the sphincter of the pyloric region is derived from the middle circular muscle and an incomplete inner oblique muscle. So predominantly is the outer longitudinal middle circular muscle and incomplete inner oblique muscle. So the wall of the stomach is muscular, okay? And you should also know about the mucosa, the mucous membrane of the stomach. It is characterized by running into folds that are described as rugae. Now, it is characteristic of the stomach, especially when you are doing an endoscopy. You tend to see the folds of the stomach that will tell you that, yes, you are in the stomach. It has many types of cells, the parietal cells that secrete HCl in the mucosa, okay? The chief cells of the mucosa secrete pepsinogen, and the enteroendocrine cells secrete gastrin, okay? Then the mucous neck cells secrete mucus. So these are the main cells of the mucosa of the stomach: parietal cells, HCl, chief cells, pepsinogen, enterochromaffin cells that secrete gastrin, then mucous neck cells that secrete mucus. Okay, now The blood supply to the stomach is supplied by branches of the celiac trunk, okay, branch of the aorta. The celiac trunk is an anterior branch of the aorta that has three main branches: the left gastric artery, okay, the splenic artery, and the hepatic artery. Okay, all other branches also arises from the branches of the celiac trunk. So these are the details. We will not go into the details of the blood supply. And you should know that the nerve supply of the stomach is derived, it is supplied by autonomic fibers derived from celiac plexus, okay? Now, parasympathetic anterior is via anterior and posterior vagi, which are responsible for increasing the peristalsis and secretion. So if you denervate the vagus nerve, the stomach will lose its contractile function. It will become atonic, okay? And also there will be decreased secretion. So if you are treating maybe hypersecretion leading to acid, if you denervate the vagus nerve, the secretion will cease, and also the contraction will also cease. It means you have to find a way of draining that content by doing a drainage procedure. The sympathetic from the greater splanchnic nerve is responsible for decreasing the peristalsis and secretion. So this is so much for the anatomy of the stomach. And for the duodenum, it has mainly four parts. Okay, the first part, shortest, widest, and the most fixed part of the small intestine. The duodenum is the first part, shortest, widest, and the most fixed part of the small intestine. It has four parts, okay? Most of the gastric outlet obstruction results from maybe obstruction of the first and the second part of the duodenum, okay? It represents a C-shaped curve around the head of the pancreas. It is retroperitoneal, okay? And it's fixed, except in the first part that is mobile. So now, what are the etiology of gastric outlet obstruction? The causes of gastric outlet obstruction are broadly classified into benign causes and malignant causes. As we mentioned, peptic ulcer disease, duodenal ulcer accounts for about 50 to 65% of cases, okay? And especially in the developing countries, you tend to see duodenal ulcer, cicatrizing duodenal ulcer, chronic duodenal ulcer with complication. Now, it could result from gastric polyps. It could be from tuberculosis, pyloric fibrosis, or maybe from corrosives. And the corrosives that usually cause fibrosis of the pylorus is usually acid, okay? When an individual ingests acidic corrosives, it causes pyloric stenosis from fibrosis. Amyloidosis, Bohavec syndrome, okay? Adult pyloric stenosis, pyloric mucosal diaphragm, pancreatic pseudocyst, and bezoars. In children, congenital hypertrophic pyloric stenosis, congenital duodenal webs are causes of GOO. Now, you should know some of these benign causes are intraluminal. Some are extraluminal, causing compression of the gastric outlet, the distal stomach, or proximal duodenum from an extrinsic compression. Now, malignant causes of gastric outlet obstruction, okay? Gastric cancer, cancer of the pyloric antrum, count for 25% of cases. Adenocarcinoma, lymphoma, gastrointestinal stromal tumor, pancreatic cancer, ampullary tumors, okay, duodenal cancer, and cholangiocarcinomas. Now, all these other tumors, especially pancreatic tumor, is an extraluminal compression, especially because you know the head of the pancreas is lodged in the C shape of the duodenum. The ampulla can also cause gastric outlet obstruction, duodenal tumors, as well as cholangiocarcinoma. Now, aside the gastric tumors and duodenal tumors, these other tumors are usually from extrinsic compression of the gastric outlet. Now, the pathophysiology of the obstruction, now it could result from edema around an active duodenal ulcer with associated pyloduodenal spasm, Now, patient might have an active peptic ulcer disease. This disease is not as a result of cicatrizing duodenal ulcer, cicatrizing chronic duodenal ulcer with fibrosis. Now, in this case, the ulcer is an acute thing. However, because of the acute inflammation around that ulcer, it is having an edema, and that will cause spasm in the muscles of the pyloric region, and that spasm will cause contraction and narrowing of the gastric outlet. Okay, cicatrization and edema of recurrent duodenal ulceration, because when the ulcer is chronic and recurrent, it attempts healing by fibrosis. Okay, now this will now lead to cicatrization and narrowing. Fibrosis resulting from simple pre-pyloric ulcer, or it could be from a mechanical blockage or extrinsic compression, okay? Now, what is the physiology? The continuation of the pathophysiology of obstruction. You know, when there is a resultant gastric hypertrophy because of the obstruction. Why is that so? From a constant and forceful contraction in order to free content into the duodenum, okay? As the lumen gets progressively narrow, the stomach is not able to force all its content, and it accumulates food and secretion, resulting in dilatation. Okay, this results in irritation by the retained content to cause gastritis, and acid secretion is depressed. Okay, you should note that anytime you have stasis in the stomach, either from accumulation of its content not moving into the duodenum, or maybe there is gastroparesis, or maybe there is reflux of duodenal content of bile into the stomach. It results in the irritation of the mucosa of the stomach, okay? And that will cause gastritis. And when there is gastritis, it suppresses the secretion of acid in the stomach. And the acid in the stomach is a form of innate immunity that tend to kill microorganisms in the stomach. Now, how do they present? Patients with gastric outlet obstruction Now, the classical presentation is recurrent vomiting, okay? You see an emaciated patient that has been sick for some time, and they will be having, their main complaint is recurrent vomiting. Of course, this vomiting is copious, effortless vomiting and projectile, okay? It contains food eaten 1 to 3 days previously, okay? The patient will tell you they can identify the food items they have eaten 1 to 3 days previously. That means it is not digesting, it's not moving down into the duodenum. And of course, the vomiting is non-bilous. Why? Because the gastric outlet is closed. Bile cannot enter the stomach from the small intestine. Okay? Vomiting may occur daily in the evening or at intervals of 2 or 3 days, because the dilated stomach is able to accumulate large amount of fluid and secretion. Now, how do you characterize the vomiting in gastric outlet obstruction? This vomiting is characterized as non-bilous, okay? Don't forget, it's a non-bilous vomiting that contain stale feeds. Is described as stale feeds. Stale feeds. Now, these stale feeds are eaten 2 to 3 days previously. The individual can still identify the food items because it is not completely digested, okay? So that is how the vomiting is. And usually they will have, okay, they usually vomit after like 3 days because they keep on eating, and the food keeps on accumulating in the stomach. It doesn't pass into the small intestine, okay? And that stasis, okay, will form a lot of irritation of the mucosa. So when it irritates the mucosa, patient tends to vomit, and they see all these features we described. Now, they have constipation. Constipation is invariable as little food or even no food enters the intestine because of the obstruction, okay? So when you see a patient that is having recurrent non-bilous vomiting of stale feet, ask for history of constipation. Now, they may have epigastric pain depending on the presence of an active or healing peptic ulcer disease. Now, if it is an active peptic ulcer disease, they will have epigastric pain. However, if it is healing and chronic, they don't usually have epigastric pain. Now, they may present with some features of complications like dehydration, and the dehydration, which we will describe later, is chronic dehydration. Don't forget, patient with gastric outlet obstruction present with chronic dehydration. They may present with shock, and because they have metabolic alkalosis, they may present with tetany, and they could have prerenal renal failure, acute renal failure. When you examine them on general examination, they are wasted, dehydrated, and pale because they could have nutritional anemia or anemia from the background pathology, maybe a bleeding ulcer or a gastric tumor, or because it is a long-standing condition leading to maybe nutritional anemia. If you examine the abdomen, okay, now the stomach is distended. Visible peristalsis is seen from the left to the right hypochondrium, okay? The gastric distension may occupy most of the abdomen and be confused with sigmoid volvulus. Now, succussion splash is positive, where patient, the hip is held and patient is rocked from side to side with the stethoscope in the epigastric region. We hear splash of gastric content. That is succussion splash. Okay. Now, a tumor may be felt in the epigastrium and or the liver may be enlarged. Such findings is very suggestive of carcinoma. Now, gastric outlet obstruction is described as a stomach that can be seen, can be felt, can be heard. So you can see a visible contraction, visible peristalsis from the left side to the right, from the left hypochondrium to the right, because of the vigorous peristalsis that is attempting to expel the gastric content into the stomach. You can palpate, okay, a mass if there is an antral tumor, okay, and you can hear succussion splash. So it's described as a stomach that is filled, seen, or heard. Now, these GOO may be from duodenal ulcers. The features suggestive of duodenal ulcers include a patient of around 40 or less. When you see a younger patient presenting with GOO, it's more likely to be benign from PUD than cancer. A long history of dyspepsia, okay, because the natural history of peptic ulcer disease or duodenal ulcer is they will have recurrent dyspepsia for a long time, okay? And that, because of attempted healing by fibrosis, they will have recurrent cicatrization from fibrosis. So they have recurrent attacks of vomiting, and there's absence of a tumor or even hepatomegaly in this patient. So when you see a younger patient with long history of dyspepsia and recurrent attack of vomiting, and you examine there's no mass in the epigastric region, the cause of the GOO is likely to be from PUD. Features suggestive of carcinoma: the patient is older. The patient of 50 years or over, a short history of dyspepsia or abdominal pain, a short history of vomiting, okay? And a palpable abdominal lump or hepatomegaly. You can see the clinical cause of malignancies are shorter, okay, because of rapid tumor growth compared to benign lesions. And because of this short history, okay, because of this short history, you hardly see a patient who is presenting with a large or prolongated stomach from malignancy that may extend to even the pelvis. This is commonly seen in patients with benign disease as compared to malignant disease because of the time it may require to achieve that, okay? Now, it is very important, especially in your exams, to understand the clinical effect of gastric outlet obstruction. Usually, you see the patient malnourished, okay, because they don't assimilate, they don't utilize most of the food content they ingest it, accumulate in the stomach, cause gastritis, and they tend to vomit out what they eat, whatsoever they eat. So a little or nothing goes into the intestine, so they are malnourished. Now they are dehydrated. This is very important. They have chronic dehydration. And when you say chronic dehydration, it's loss of fluid from both the extracellular fluid as well as the intracellular fluid. It is a long-standing recurrent vomiting that leads to chronic dehydration. It's not something that causes an acute depletion of the intravascular volume. So they have hyponatremia, hypochloremia, hypokalemia, which worsens by paradoxical aciduria. They have metabolic alkalosis. They may present with prerenal renal failure and anemia. Now, it is expected that everyone should be able to explain how all this electrolytemia results from. Now, we are going to see the concept of paradoxical aciduria and how all these electrolyte abnormalities develop. You should know in GOO, there is a non-bilous projectile vomiting, which causes gastric acid HCl loss. And when they lose this HCl, which is the predominant source of acid in the body, they consequently develop hypochloremia. So they will have hypochloremic metabolic alkalosis. Why? Because they are losing acid. So they develop metabolic alkalosis. And because the acid they lose is HCl, that's why they develop hypochloremia. Okay? So you should know they have hypochloremic metabolic alkalosis. Now, you should know initially the urine contains less chloride and more bicarbonate. Okay? As the form of what? Sodium bicarbonate. Now, because this patient is already alkalotic now, because he has lost so much of acid, they have metabolic alkalosis. The body wants to get rid of this metabolic alkalosis, so they tend to lose a lot of alkali, okay, which is bicarbonate in the urine. And this is lost in form of sodium bicarbonate. This is lost in form of sodium bicarbonate. Okay, so you can see this alkali that is lost in the urine is going along with sodium. Okay, and when there is loss of this sodium, they develop hyponatremia. You can see they are losing sodium in the urine, they develop hyponatremia. If you look at the vomitors also contain sodium. So they are losing sodium in the vomitors, they are also losing sodium in the urine, they have hyponatremia. Okay, and anytime a body suffers hyponatremia, there is release of aldosterone, okay? There is release of aldosterone, and this is to help in conserving or retaining sodium. So this phase allows more sodium and water reabsorption in exchange of potassium, okay? In exchange of potassium. So because the vomitors also contains, okay, potassium, and now the urine is losing potassium in exchange for reabsorption of sodium and water due to release of aldosterone. The patient also develop hypokalemia. Okay. So now, you see, we've described how they develop hypochloremia. We've described how they develop metabolic alkalosis. We've described how they develop hypokalemia, okay, and hyponatremia. Now, if the patient keeps on losing potassium in the urine, it gets to a critical level in which the body can no longer tolerate potassium loss. It now switches the loss of potassium with hydrogen in exchange of reabsorption of sodium and water. So in reabsorption of sodium and water, rather than losing potassium in the urine, they now lose hydrogen ion. And when they lose hydrogen ion in the urine, that urine becomes acidic. Now, it is a paradox. That will be called paradoxical aciduria. Why? Because patient has metabolic alkalosis and they are losing acid in the urine. That is a paradox. If a patient is metabolic, is alkalotic, why are they losing acid in urine? That's why it's paradoxical aciduria, because in the presence of metabolic acidosis, kidney should have produced in the presence of metabolic alkalosis, kidney should have produced alkaline urine. However, they are producing acidic urine. And you should know that alkalosis decreases plasma ionized calcium. Anytime you have alkalosis, it decreases the calcium is being the calcium, ionized calcium tend to mop up the bicarbonate, okay? It mops up the bicarbonate, so it reduces serum calcium, and hence patient will have hypocalcemia, and they will now be presenting with symptoms of hypocalcemia, which is tetany, okay? So to summarize this electrolytes derangement in gastric outlet obstruction, gastric outlet obstruction is described as a patient is having, okay, a patient is having hypochloremic, hyponatremic, hypokalemic, metabolic acidosis, and paradoxical aciduria. And they may have hypocalcemia, okay, because of the alkalosis. Now, this is the summary of the electrolyte changes in a patient with gastric outlet obstruction. So you should know when a patient vomits, they vomit HCl predominantly from the recurrent vomiting. And this HCl leads to, because they lose acid, they have metabolic alkalosis. And because they lose this chloride, they have hypochloremia. Okay? Now, because of the alkalosis, the body tends to lose alkali in form of bicarbonate, okay? And this is sodium bicarbonate. So they tend to adjust by getting rid of a lot of alkali in form of sodium bicarbonate in the urine. And because they are losing the sodium along with bicarbonate, they develop hyponatremia. Not only in the urine, the vomitors also contain sodium, which worsens their hyponatremia. And this hyponatremia will stimulate release of aldosterone, which will cause reabsorption of sodium and water in exchange for potassium in the proximal convoluted tubules of the kidney. And there is further loss of potassium in conjunction with the potassium loss in the vomitors. There is loss of potassium also in the urine, and this potassium loss will lead to hypokalemia. Now, because of the essential use of potassium in both cardiac and excitability of the body, potassium hypokalemia gets to a critical level that the body can no longer tolerate. It now switches reabsorption of sodium and water in exchange of hydrogen ion into the urine rather than potassium. It is now conserving the potassium. And the patient, because of the acidic urine they are having now, and they are alkalotic, so they have paradoxical aciduria. It is a paradox because patient is alkalotic and they are producing an acidic urine, okay? And they have hypocalcemia from the alkalosis. Now, don't forget they have chronic hydration. So that is the summary. A patient with GOO has chronic dehydration, hypochloremic, hyponatremic, hypokalemic, metabolic alkalosis with paradoxical aciduria, and hypocalcemia may be present. Okay. So this patient, how are they investigated? Usually there are some basic investigations that are done that are preliminary, but you should know the ultimate gold standard in investigating patient with gastric outlet obstruction is to do an upper GI endoscopy with biopsy, okay? Because you visualize whatsoever is causing the obstruction, and if there's a lesion there, you take biopsy. But some preliminary investigation you should know of, especially if you are in centers where where upper GI endoscopies are not readily available. You can do a plain X-ray which will show a large gastric shadow and a large amount of gastric fluid in it, just a plain abdominal X-ray. Okay. Now, gastric aspiration using a wide bore NG tube, okay, is passed early in the morning and the stomach is aspirated, okay, of its resting juice. Now, if in the morning you aspirate more than 400 mils of gastric juice, okay, it's presumptive of diagnosis of GOO, okay? So, because most of the contents are supposed to move into the duodenum, especially in the mornings, okay? And now in the morning, you are aspirating more than 400 mils. Now, barium meal is also an investigation that is requested, especially if GR endoscopy is not available. Barium meal, a barium contrast is ingested, then an X-ray is taken. It shows a markedly dilated stomach with lots of residue. So because of that appearance of content of the residue is described as mottled appearance, and that is retained food particles. Part of the stomach may be in the pelvis. There is a delay of emptying, and most of the barium is in the stomach at 6 hours, which, you know, gastric emptying time is 3 hours. And now, after taking contrast, the contrast is still in the stomach at 6 hours. And of course, in some cases, up to 24 hours, the stomach still retains the contrast. In chronic duodenal ulcer, no feeling of dye in the second part of the duodenum. There is absence of duodenal cap due to spasm of the first part. In carcinoma of the pyloric antrum, there is a filling defect, okay? that marks narrowing. Okay, you will just see, if you do that, you will just see a filling defect around the antral region. Okay, this will now cause narrowing, okay, of the antrum. As mentioned earlier, that endoscopy is the gold standard for diagnosing gastric outlet obstruction. However, before endoscopy, you have to do a gastric lavage. After lavaging the stomach, okay, with saline, then if gastric tumor is seen, you take a biopsy. Okay, in duodenal ulceration or fibrosis, the antrum and pylorus are normal or edematous. So you take a biopsy for histological diagnosis. Now, in the treatment of GOO, you commence with resuscitation. And you should know the fluid correction is not rushing fluid because patient has chronic dehydration. If you attempt to rush fluid, patient will have fluid overload and they may come up with a central pontine demyelinosis because it is chronic dehydration where there is both ECF and ICF loss. So correction of fluid and electrolyte, you use predominantly normal saline. Never use Ringer's lactate. It is contraindicated because if you use a Ringer's lactate, that lactate is converted to bicarbonate in the liver, and that bicarbonate patient already has metabolic alkalosis, okay? Now, you never add, please don't add potassium when correcting dehydration until patient is making adequate urine, at least 30 mils. So 30 to 50 mils per hour. Then you check daily urea and electrolyte in the patient. Now you have to check the full blood count of the patient after rehydration. If there's any anemia, you correct, okay, by giving pack cells. Don't forget, you have to maintain nasogastric tube for lavage, okay, so that you'll be lavaging that stale feeds that are in the stomach, okay? Yes. Now, the non-operative management, you see the initial presentation is to stabilize the patient by correcting the hydration, doing a gastric lavage, okay? And if there's any or evidence of sepsis or chest infection, because some of them may come up with what? Chest infection from recurrent vomiting. They might even aspirate their vomitors and come up with chest infection. So you have to settle all those problems during the stabilization or resuscitation of the patient. You do gastric lavage. Now, for obstruction due to duodenal ulcer, especially an active duodenal ulcer forming an edema, there's an edema around an active duodenal ulcer leading to pylorospasm. You have to lavage, pass wide caliber NG tube and lavage with saline. How will you know that your lavage is sufficient? The edema and the spasm have subsided around the active ulcer. The way you know that is that bile appears in the aspirate. You start seeing bile in the content of the fluid you are aspirating during the lavage. It means that obstruction is open and the duodenal content is entering into the stomach, okay? When you achieve that, you can now commence a graded oral seeds, okay, as patient tolerates. Not that you go and load patient with solid foods again. Now you can do endoscopic balloon dilatation. Okay, this is only temporary. The benefit is only temporary and has high rate of recurrence. It's just a palliative measure, especially in elderly people. Okay. Now you can do some operative procedures. Now the operative procedures that are done, you do a vagotomy and a gastrojejunostomy. Okay, especially these recurrent ulcers. So you do vagotomy, it will reduce the gastric secretion so that the ulcer will heal. Okay? But remember, if you do a vagotomy, you are denervating the stomach, it will lose its contractile as well as the secretory function. So there will be more stasis in the stomach. So you have to do a bypass by doing a gastrojejunostomy. Okay? So this is called vagotomy and a drainage procedure. Now, BROD 2 is also a gastrojejunostomy. Okay, you might do gastrectomy before doing a period 2. Now you can just go straight ahead and do a gastrojejunostomy, especially if patient is too sick, malnourished. Just go ahead. Most of the time, those patients that come are too sick, so we don't even waste our time doing extensive surgery. We just do a drainage procedure so that you bypass the obstruction. You do a gastrojejunostomy. Now, subtotal gastrectomy in patients who have gastric cancers, especially antral cancers. We won't go into the details of that. If it is polypectomy, you excise the polyp. Now, other causes of gastric outlet obstruction for that are extraluminal, okay? The causes, the conditions are treated as appropriate. So we've come to the end of this lecture. Now it's question time, clarification time. If you have any question, you can unmute your mics and ask. So thank you very much for participating. Okay.
Assalamu alaikum, sir.
Wa alaikum assalam.
Assalamu alaikum, sir.
Wa alaikum assalam. Dr. Tijani, how are you?
Thank you very much for the lecture.
You are welcome.
Fine, sir. Thank you very much for the lecture. It was really when you were talking about benign causes, my questions are really that got to mind. So first is when you are talking about benign causes of gastric outlet obstructions, you mentioned some syndromes. I'm interested how those syndromes can be related to pathophysiology of the. You mentioned like there is one buffer syndrome like this. So how is it related to those pathophysiologies? And again, the second question, this goes to the treatment modalities. At what point in time you need to choose the best form of treatment? When you talk about non-operative causes, then surgical causes. At what point in time we need to choose? Then still under that, another top part of the question is you also, when you're talking about investigation, let's say you mentioning all those normal baseline investigation like football can and differential and all this one you said. So just went to endoscopy, barium mean, and so those specific investigations. I didn't see that. Maybe I don't know. Maybe I'm the one I'm missing. So I didn't see you mentioning baseline investigations as regards to what's to be done for the patients. And, thank you very much. Those are my questions. I don't know. Maybe I'm clear. No.
Okay, yeah, those are very
Thank you
good
very much, sir.
questions. You are welcome. Especially this last question you mentioned is a very important question regarding the investigations, the baseline investigations. Okay, now generally, anytime you are managing a surgical patient, okay, the investigations are classified into 3. Okay, anytime you are managing a surgical patient, okay, your investigations are classified into 2. Number 1, diagnostic investigation. 2, investigation to determine stage of the disease. And 3, investigations to prepare patient for treatment, okay? Now, diagnostic investigations are those investigations you do, of course, to get a definitive diagnosis to treat. You want to know what is the pathology, what is the pathology, so that you treat. You do main diagnostic. The diagnostic here, you do basically histology. You want to take a sample. You want to get a histologic diagnosis. Okay. So that is one. Like for GOO now, the diagnostic investigations here is the ones that I mentioned, where you just go and do your endoscopy, visualize the stomach. What are the things you see? You will see a roomy stomach, number one. Number two, you will see loss of rugae, the rugae of the stomach we describe in the anatomy. Those folds will disappear because of the recurrent gastritis. Then you will now see maybe a mass in the antrum if it is from cancer, or you see an ulcer, chronic ulcer. Then you now take a biopsy for histological diet. That is the most important investigation. Now, when you are dealing with malignancies, you want to know the stage of the malignancy. So you do staging investigations like chest x-ray, CT scan of the chest and the abdomen to look at the liver or distance spread, okay? Then investigations to prepare patients for treatment. These are the baseline investigation before you commence any surgical treatment. Of course, you are going to do baseline investigations like full blood count. If there's anemia, you correct. Of course, if you want to correct anemia in this patient, you have to do your full blood counts, okay? Then your urea electrolyte creatinine, your fasting blood sugar, okay, your grouping and cross-matching, all those baseline investigations. So this is applicable to all surgical conditions. So if you are answering a question in exam, this is the approach used in answering the question. So it's just, these are just deliberately removed from the lecture just to summarize. But if you are presenting and giving detail, not only in GO, in all surgical conditions, you have to classify your investigation. I hope that answers your question. Then you asked a question on the...
Yes, sir.
You asked a question on Bovaret syndrome. Okay.
On the
You
yes,
said
yes, sir.
syndromes, Bovaret syndrome, and what again? Which other syndrome?
The Bovet syndromes and this um, pylori mucosa diaphragm. So I just want to relate it to pathophysiology. I want us to then what's the content of the syndrome that make it so correct with the pathophysiology?
You should understand
That's
if
because
you
the
if you look
syndrome
at the
itself.
okay. If you look at the pathophysiology of GOO, the obstruction could either be intraluminal, okay? It could be intramural, arising from the muscle, or it could be extraluminal.
Yeah.
Okay, if it's you have maybe bezoars, maybe hair, it's intraluminal, or foreign body from phytobezoars or trichobezoars, that is intraluminal. If you have corrosive, causing stricture and narrowing. This is intramural. Okay. Then if you have compression from a tumor in the extrinsic uh, surrounding adjacent structure, that is extraluminal. This Bovery syndrome is just a rare condition. It's a rare condition. There's what is called gallstone ileus. Gallstone ileus. There are various ways. Okay. There are various ways a Bovery syndrome presents. One of the ways, but this is not something very common. Okay, where you have a gallbladder stone. You remember gallbladder and the duodenum. You have a stone in the gallbladder. It's adhering now to the, okay, it's adhering to the second part of the duodenum. Okay, this stone can cause extrinsic compression here. One. Two, it can cause a fistula by burrowing through the wall of this gallbladder and entering into the duodenum, okay? And it will now go to the terminal ileum and cause blockage there. The stone can be so massive that it can occlude this lumen, or it can even move down to the terminal ileum and cause obstruction. Okay, so it's just syndromic. It's not very common. Okay, you should know it's just one of those rare syndromes where you have fistulous connection. It's a form of internal fistula where a large stone in the gallbladder will compress on the second part of the duodenum, causing an extrinsic compression, or it can even cause communication, and the stone enters into that duodenum and cause obstruction there, or it can even dislodge up to the terminal ileum, causing intestinal obstruction. Yes, I don't know if it is clear. Yes, Dr.
Yes, sir, it is clear. It is
Yes,
clear.
the third question was
Thank you, sir.
regarding surgery. You said about surgery something.
Yeah, I said about at what point in time do we have to choose the best modality of treatment, whether not operative or operative?
Okay.
At which one do we have to?
Yes, that is a good question. This
Yes,
depends
sir.
on the cause. That is just the answer. It depends on the cause. If it is due to edema around an active duodenal ulcer, you don't operate. You do non-operative treatment. You just pass NG tube and be lavaging, okay? Removing the gastric contents. That recurrent lavage will cause the edema to subside. And when you start seeing, what do you call it? Bile in the content of your lavage, you know that it is the edema has, you have get rid of the edema. Is that clear? So edema around an active peptic ulcer, you
Sir,
don't.
yes, sir.
But when it is a tumor or when it's a mechanical obstruction, you have to operate. Hope that is clear.
Yes, sir.
Okay. Any other question?
Thank you, sir.
You are welcome. Any other question?
Yes, sir. What's the leading cause of mortality in gastric outlet obstruction patients?
Okay. Mortality. Usually, you see, patients have a wide spectrum of problems or complications, and this will interplay with each other to either cause metabolic derangements. A patient will have dyselectrolytemia from chronic dehydration, okay, from that recurrent vomiting. So at the same time, they have malnutrition with immunosuppression, which will predispose them to sepsis. They may have recurrent chest infection, okay? Then they may even have renal failure. They may be having metabolic alkalosis and tetany. So most of the time, the disease progresses. And when there is no proper treatment, it tends to progress into a multiple organ dysfunction and multiple organ failure. But the most important problem they have is the dyselectrolytemia and chronic dehydration. But all in all, what you should know as a cause of their problem or major problem is when there's interplay of all the complications that develop as a result of the problem. And the reason why you don't have a single pathology that you can isolate as the cause of you have a wide spectrum of causes of GOO. You have a long list of benign causes. You have a long list of malignant causes. The GOO itself is as a result of the interplay of the complications of GOO. Don't forget they have a background pathology causing the GOO that will take its natural course. Okay, if it is malignancy, it will take its natural course. Okay, if it is benign, there will be disease progression and so on. I hope that is, yeah.
Yes, it is. Thank you.
Yes, any other question? Okay, I believe we don't have any other question. If there's no question, I think we are going to stop here. Okay, thank you, everyone.